Good afternoon, everyone, and thank you for joining us for the fourth and final webinar in our Business Sustainability, COVID-19 Recovery, and Adult Day Healthcare free webinar series. My name is Jeff Diamond, and I'm the Policy and Communications Manager for Leading Age New York. Before we get underway, I'd like to quickly go over a couple housekeeping items. If you have any questions during the presentation, you can type them into the Q&A box in your webinar controls. We will also be emailing the handout and a brief evaluation to all participants once the presentation has ended. Today's webinar is titled Rebooting ADHC Programs, Planning and Preparation for Reopening Safely in a Coronavirus Environment, and our presenter is Gail Weinstein. Gail is a New York State licensed nursing home administrator and certified therapeutic recreation specialist with more than 40 years experience in hands-on, supervisory, administrative, and consulting positions. Since May 2000, she has provided long-term and ADHC private consulting services and served as a per diem consultant for Leading Age New York ProCare. At this time, I'd like to turn things over to Ann Hill, Executive Director of the Adult Day Healthcare Council, for some brief remarks.
Thanks, Jeff. Before I pass the presentation on to Gail, I want to thank Gail and all of our speakers in this webinar series. I also want to thank the team at Leading Age New York, Jeff, Bill, and Michelle, for all the technical assistance that you've provided. We had just a few weeks to pull all of these webinars together, and I really appreciate all of the hard work that you did to make this webinar series happen. So opening adult day healthcare is our #1 priority right now. We submitted a proposal May 29th to the state, and since then we have met with a number of DOH staff. We've revised our proposal and resubmitted it to the team, DOH team, and we know that they're actively engaged on this issue. In fact, they're meeting again tomorrow to speak internally about reopening adult day healthcare. So I worked closely with Gail on this presentation, and the content is based on the feedback that we've received from DOH. So while nothing is set in stone and we don't have an opening date set, we do have a lot of information to share with you today. So if you have any questions, I encourage you to submit them through the chat button. Also, you can contact me after the presentation today at ahill@leadingageny.org. So thanks again, Gail, and all of our speakers. Thanks, Jeff, Bill, and Michelle. And Gail, I'm going to turn it over to you.
Okay. Welcome, everyone. Today's webinar is obviously going to be focusing on all the specific components that are necessary that we need to address and implement prior to its opening. I'm also going to be incorporating the pertinent information from the prior webinars, including the infection control, team building, and telehealth, considering that all of that applies to our adult day healthcare programs and its opening. I'm also going to, I just want you to keep in mind two things. First of all, what is applied for us is not just ordered from the Department of Health or CMS or the governor related to only adult day healthcare programs. It is in fact the main understanding that what applies to the nursing home at this time applies to adult day healthcare programs. And also keep in mind, as Ann said, that we are doing everything and we are saying everything as facts today based upon as we know them today. Things seem to constantly change. And so as they do change, Ann will, be communicating through emails and all information so that you will have the latest changes always. Okay, so now I'd like to get started on the nitty-gritty. This is an outline that you can use kind of as guidelines so that when you open, it helps you put all the different factors in place. Also, later on, I'm going to be talking about an accountability sheet, which if you use can be very helpful in at least minimizing some of the overwhelm that we'll all be facing. Okay, so to start, let's talk about the PPE, the personal protective equipment. Obviously, you're going to need to check current inventory. And inventory where? Are you getting it from the nursing home? Are you getting it from outside contractors? We need to find out what the inventory is, where we are going to be getting it from, and being sure that we maintain a 60-day or 2-month supply. That is based on a recent order signed by the governor that it is required that we maintain a par level for at least 2 months supply, 60 days. Also, when we talk about the kind of equipment we need, we have to realize that while we know that we're looking at the masks, face shields, while they may not be mandated, may be necessary for your population, maybe depending upon the service that you're actually providing, how close you are to that population, to that individual. Maybe you have some clients who happen to spit. And if that's the case, then for sure, you're going to want to have a face shield, whereas you may not need it for some of the other people in your program. So once again, we're looking at things that are more individualized for your safety as well as theirs. When we get the supply, we need to know who's delivering it. Where is it being delivered from? Where is it going? All of these little details that we generally handle on the spot, now that they're so new, we really need to have a policy and procedure in place, or a protocol, however you want to work it. But it should really be a protocol or policy that specifies who is doing what by when. Where is the delivery coming from? How often? Where is it going? Who is receiving it? Are they entering the program? Hopefully not. So all of these factors that we never even considered before, we really need to take a look at now. The 60-day supply is not a negotiable number right now. It is not fluid. We have to keep in mind that some of these things, as they're mandated, we may not love them. We may feel that they're not necessary, but the bottom line is if they're in order, then we have to adhere to them. Finally, we added under PPE to track all expenses. We may be facing future audits down the road. This could be helpful for future planning and even for possible future reimbursement. So it's really important that you track all your expenses to make sure that whether it has to do with the PPEs, whether it has to do with staffing, whether it has to do with environment, whether it has to do with the supplies that are not even the PPE, all the things that you are doing and putting into place specific to COVID-19, you should be keeping and tracking all the expenses. Okay, let's go on to staffing. Staffing, the first thing we want to know is, are all the staff willing to come back? We want to know, before we even ask the question, how many and who, we want to know, are they willing to? Are they expecting to return? And then we want to know from our CFO or our administrator, what are the finances looking like? And how many staff can we have? And before we go and ask that question, we kind of want to know how many registrants we're going to be having at a given time on a given day, so we know what type of staffing we are going to be asking for, that at least will be able to meet the social distancing and the needs of our registrants. So, okay, so now we're going to take a look at who do we want back, which staff, which disciplines, and how many. And then we want to really make sure, remember they had talked about team morale. Well, we want to make sure that every staff member who is willing to come back, in fact, we want to give them an equal opportunity to come back. So if we are going to stagger staff or have staff on certain days, rather than keep the same staff, if we're not having everyone, then we want to try to rotate them so that we give everyone a similar opportunity. It will help their morale. It will make them feel, as much as we missed them, now they'll know how much they were missed and how much they're appreciated in coming back. So that was an important point in one of our webinars that was addressed in terms of trauma that was faced, experiences that they had over the last 3 months, and now coming back, their team morale. Then we want to take a look at what time frames do we want the staff there? Do we want the staff, if we are able to run less hours each time, and hopefully the staff will go along with that because it really is in the interest of our registrants as well as COVID-19 and social distance. If we can do that, then are we having some staff for part 1 and other staff for the next shift? How are we doing that? Are we staggering times? Are we staggering the days? All of these questions you want to take a look at so that you know how best to manage the staffing. The next thing, which is really critical, is the screening and the testing process. Who do you want to screen? Everybody, but when, where, and who will do the screening? And we know that there are those set questions that everybody is going to be asked, so we're testing to that. But then the next question is about them being tested prior to them coming into program. And then what happens, and you know you're going to be facing, what happens if staff call in sick, or they can't pass the screening, or they can't be admitted to, and can't be admitted to the program? Or what if they become ill at the program and then need to be sent home? Do you have contingency plans, a place to go to for staffing that is absolutely necessary for your registrants and to provide your services? What happens if you're suddenly looking at short-staffed? Where do we go? Another thing to think about is, are you at all looking at agencies? If you are even considering going to an agency for a nurse or looking at it as a possible backup or a CNA, then you'd need to talk to the agency, talk to the people, and let them know what your expectations would be with regards to the staffing who would be coming into place. Another thing that we thought about is union. If you are dealing with staff who are in the union, then you want to make sure that everything you're putting into place, that once again, people will work together, and that maybe you have to waive some of the policies that are in place. And I think at a time like that, we have management and we have union and we have staff and we have families, and I think everybody's going to be on the same page, so we really should not have any issues, but it does require at least addressing and attention. And then for all these things that are identified in 2D that we just went over, you should have a policy and procedure that you develop specific to identifying who's doing what, how often, when, and what if it can't be done, what do we deal with? Okay, so if that's not enough overwhelm, and we all realize, look how much we do all the time for all our registrants and for all our families when it's not during COVID. Now, of course, there are so many other factors that we need to focus on and adhere to. So obviously, it's going to be a very difficult time. But the plan was that if we break this down into different categories and components, and then different bullets under each one of the categories, it will help us take a look at what needs to be done, who's going to be doing it, by when, and then it should help reduce any chaos or overwhelm. So now let's take a look at managed care. This could be a difficult or a long-term process, which we don't want it to be. So if it's necessary, we should ask our CFO or whomever we feel is a good person with some clout who can help facilitate and expedite the process if in fact it looks like it's taking too long to confirm. And when we work with our managed care, we want to make sure that not only about authorizations, but we want to communicate to them what are our expectations as well. What do we need to do by law, by sticking to DOH and CMS guidelines, by following what the governor is saying, and all in all, to be sure that we're meeting our registrants' needs, what are our expectations from them? And then we want to review the COVID testing and screening requirements specific to our managed care. Physician authorization. So we're looking at their primary care physician. Up until recently, we were thinking that if the physician signs that a form that says that they are free of communicable disease, that we would be good to go. However, Department of Health is not in favor of that, and that's putting it nicely. What they want is for an initial baseline testing for registrants to be able to return to the program. And so at least that was the last thing that was communicated during Ann's conference call with them. And so whether that changes, well, we don't know that, obviously. But appropriate for the program is one thing, being a medical model, but the other important aspect is that free of communicable disease needs to state that, in fact, they have negative testing done, negative testing outcome. And also, we could find out and let our registrants and families know that they may be able to continue with virtual health, virtual or telehealth calls and visits with their physicians. Many physicians are coming back. Many physicians are still looking at doing the telehealth and virtual visits. And depending upon what their primary is doing, may take care of a lot of different things and help facilitate their visits. Certainly, we're going to need to be in contact with their physicians as always, because based upon our code, we always know that we need to have the physical and history 6 weeks prior, 7 days after, but now we really should have all of this information upon arrival, that we know that these people are safe for themselves, safe to each other, and safe for staff as well. So that would be for the physician authorization. In taking a look at outside vendors and visitors, bottom line is that unless absolutely medically necessary, effective June 25th still, there are no visitors unless staff or visiting is essential. And so that may mean, for example, if you have the clergy, we're not doing. Entertainment, we're not doing. Pharmacy consultant. So are we having that person come in, or can that person do it remotely? If they are coming in, then they need to be tested and have proof of a negative test results, and they have to sign to attest the fact that all the screening questions work for them to be admitted and coming into the program. If we are having a physical therapy consultant, I don't know whether we have our own staff or some places, some programs actually contract with an agency or individuals separately. And if they are coming in to provide the service, they too have to be tested to show that they are negative before coming in. All staff, just like in the nursing home that we have to be tested once a week. And so keeping all that in mind, we have to be really clear who is coming into the program. One of the things that I do want to talk about is your transportation. Now, we're going to get to that, but the bottom line is some of your programs, I know staff goes out to meet the buses and the vans, and then they help the registrants come into program. There are some other programs that have the drivers and matrons bring the registrants into program. That needs to be reconsidered. That should not be done, because once again, it is not essential that they do that. And then anybody coming into program, we would have to know that they are negatively tested and that they pass the screening questions. So I just put that in as an outside vendor. And the other piece is that you should have a sign-in sheet where it will have the name, the date, the reason for the person being there, and also indicate that you have seen their negative results, and that you have the report, so you can date that as well. All the information that you can have, that you can track, that you can have as a record, keeping as a record, is really not only in our best interests in general, but certainly if there's ever auditing coming into place, if there's ever fiscal concerns. So all of these records and guidelines regarding maintaining operational adherence to the regulations and orders is really important that we do. Okay, continuing. Food, meals, snacks. So with that, we all know that we have to have tables 6 feet apart, but we have to take a look at where is the food coming from? How is it being transported? Where is it going when it arrives? How are people being served and the food being distributed? And how are registrants being fed? How and where? And by the way, under normal circumstances, obviously we can't use disposable tableware, but during this time, which is state of emergency, DOH it's totally acceptable to use disposable tableware. So once again, is it coming from the nursing home? Is it coming from restaurants? Where is it coming from? Where was it coming from? What changes might you have to make now? And then who is transporting it? Where is it being transported from and to? How are we serving our registrants once they're in program and seated at the tables? And when any of our registrants require to be fed, how are we doing that? How are we keeping masks on for the staff person? Obviously, when they're eating, registrants can't have a mask on, but what are we doing socially distant? What are we doing to keep everyone safe? Transportation vendor. So you should have developed a plan and an agreement with the transportation vendor that addresses the testing and the screening of drivers. The testing is vendor responsibility, but we want to make sure that they know that and that they follow that. PPE supplies, what's appropriate. We want to make sure that they know how to use them and how to remove them. Removing them has come into play now as being a very important concern. All over, people are discarding them inappropriately. They are taking them off their hands or face inappropriately. They're using a mask intermittently. They're touching their face. All the different factors that need to be looked at as part of the infection control, and Dawn had gone over them, needs to be followed and implemented, and assure that everyone knows not only what to do, but how to do it appropriately and effectively. Program expectations. What does the driver and matron need to do, including the screening? Where are we screening them? If we're screening them, are they coming into program? What do we want them to do about taking registrants. I spoke to a couple of places where drivers, transportation place, a company was willing to have their drivers take a look at the screening and then not take anyone who didn't pass the screening. So they would ask the questions, and then if the registrants didn't pass that, then transportation would not be bringing them in. What is the policy that you're going to want to put into place? Do you want them to ask those questions? Then are we doing temperature training and screening when they come to us? Where will we be doing that? Who will be doing that? How will we be monitoring that? What about sitting on the vehicles? I know that there are some transportation companies that are providing services now to certain places, observing social distance, but instead of having 15 people on a bus, they have 4. How are we accommodating that? How are they accommodating that? And what are they doing to have some flexibility to make it all work for everyone involved and to be sure that we are safe and compliant? What about the routing? You know that if we had 15 or 20 people on vans and buses previously, and we can only do 1/3 of that, then are we just taking those people in on those few buses? Are we having double runs? How are we doing what we're doing to get in as many people as we can safely serve? How are we doing that with the transporting on the vehicles? Again, the routing. A lot of times they would have people in one area and pick them all up at the same time. But if that's too many people to accommodate social distancing and safety, then what? Maybe we need to look at that routing together with the transportation vendor. And finally, the cleaning and disinfection of vehicles. It takes hours in between to do this. And how are they doing it? Are they doing it? I'm sure that they are and they will, and I'm sure that they're going to do it based upon all regulations. But we, of course, want to just not take anything for granted. We want to make sure that all this information is put into an itemized agreement that you can go over and review with them. It is a recommendation that perhaps you would consider having them sign this agreement and that you could sign it so it's mutual understanding. It's not about tagging them as though they're doing something wrong. It's just really to make sure that everything is being done correctly. Okay, let's take a look at the registrants. So when you're dealing with the registrants, first of all, what the state is saying, Department of Health is saying, is that they are expecting you to dramatically reduce capacity. We don't know what that number means. We have some ideas, but nothing is concrete. And what we even think today might be very different later today or tomorrow. But again, we are looking at it opening with a dramatically reduced capacity. So now, based on what that capacity will look like as per allowed, then we have to take a look at how many registrants can attend at a time using social distance guidelines. What can we do with our environment? Do we have them in 2 separate large rooms? Do we only have 1 room to do everything? There's so many different programs and so many different rooms and sizes. And so each program has to evaluate their own as to how, in fact, to plan for this. And then when you take a look at the anticipated attendance, then you're going to be taking a look at, again, are we staggering times in one day? Are we having a couple of shifts in one day? Still, never more than allowed, and never more than individual visit billing. So based upon what we're looking to do, will not have any negative impact on state's money, but we'll get our people to come in, and hopefully we will be able to serve based upon what we're looking at and hoping for is staggering times. Also, we have to take a look at what is the method of transportation that the registrant is going to be using. Are they using private, public? Are they using a transportation vendor? How are they coming in? Because once again, that makes a difference on the transportation vendor services, how many people they have to put on the bus, how many people they're actually picking up and returning. And sometimes when you do this investigation, you may find that some registrants will be brought in by family, but are needed to be returned by the transportation vendor, or the other way around. Maybe some families will feel, no, we're going to bring the person in and out and take them back because we want to be safe. But then again, there are many families, if they're going to work, and they cannot be responsible for the transportation, so they're going to hope that our vendors do that. But we need to get a good handle on how many of our registrants will be using what kind of transportation, with what kind of frequency, in what kind of direction. And then we have to take a look at the registrants in terms of D, whether they are safe. In the past, we have always been able to say we cannot accept or we need to discharge a registrant who is considered to be a danger to themselves or to others. Well, if we have someone who resists or refuses to keep a mask on, or for medical reasons cannot keep a mask on, are they coming into program and we can find a safe place for them and know that we are treating them and keeping them safe as well as the other registrants and staff? Or do we find that maybe they were not appropriate right now to come into program because of what they can do, can't do, refuse to do, resist to do? We need to look at all those things. Once again, all of our registrants are different. So some people may have behaviors that warrant them to mean that they can't follow the directions or they don't want to follow the directions. You may have people with dementia who won't remember to follow the directions. So all in all, you need to look at your population and how that manifests itself, and whether or not those registrants should be admitted, can they be admitted, and then can they be managed safely. And then you should be developing a plan to perhaps provide telehealth for registrants who may be deemed inappropriate, or who, for whatever the reason, maybe they don't meet the screening or the testing, and so they can't come into program. But we want to continue to have their needs addressed, and so we should have a plan in place as a supplementary telehealth services as well. Okay, so if that's not enough, now we have to look at our families and caregivers. So we have to discuss the plans before opening. We have to talk to our families and caregivers and let them know exactly what it is that we're putting into place to follow regulations, and most importantly, to keep their family members safe. What infection control measures are there? Socially distant measures. What are we doing with the activities? What are we doing all over the place to make sure that their family member is safe? And then we want to describe to them, what are our program hours? What are we doing with our staffing? What are our screening and testing policies and visiting policies? We want to be sure that they know that things that were working and were accepted before are not acceptable now. for the safety of their family member, for the safety of them when the family member returns, and for the safety of all the other registrants and staff as well. So they need to know all the different parameters of what we are putting into place. Additionally, we want to discuss with them, it's very important that we have a plan in place that what happens if the client doesn't pass the initial screening, the questions, and they can't be accepted to program? Or what happens if they become ill and need to be sent home? Or what happens if they need to be transferred to the emergency department? What do we do? Can they meet us? Where will they be? What happens with emergency care? What is acceptable, what isn't? And it is also important that we have a place for isolation, where if we have any registrant who in fact becomes ill, and now we're not sure why, but we have to transfer them either back home or to the hospital, whatever is deemed appropriate, where are they going to stay so that they're not on top of other people, even within that 6-foot limitation? Can we have isolation in some area, again, for the safety of everyone? And then we should have a plan in place and develop this in writing, and let staff, families know that in addition to all these contingency plans that they're agreeing to, they need to be assured that if we are made aware, if anyone becomes ill at program, or we become aware that anyone has been ill, whether it's staff or registrants, anyone at all on any of the days, whether their family member is there or not, we will be sure to communicate to them no later than 24 hours after we have received notification. I think that's very important, because even with families now dealing with their family member in nursing homes, they have so many questions, and they are always looking to make sure that things are communicated in a very timely basis. So we want to make sure that our families are comfortable sending in their family member, knowing that they will be treated with the utmost of safety concerns, infection control aspects, and everything else. So that again is another policy and procedure, another protocol, another agreement. But these things help assure everyone and help make sure that mutually understanding is out there, is accepting is out there, and that we don't have any other issues down the road that we're not planning for. Okay, let's take a look at environment. So with the environment, we want to evaluate it, obviously, for social distance seating and implement the necessary seating plans. We want to take a look at the tables and chairs, spacing. How do we accommodate all of our registrants? How do we accommodate the staff? We want to make sure things like our water fountain, water coolers, vending machines, things that are really shared equipment should be off limits. It should be non-operational during this time for staff and for registrants. Everyone really needs to know that we need to be very careful. And it's on things that we don't even think about, but anything that is shared equipment should be off limits, or clearly disinfected immediately if it's something that we really need to have. Housekeeping. So we want to develop a policy and procedure that reflects the cleaning, the sanitizing, disinfecting all pertinent areas to prevent transmission of this virus. We want to follow the policy of the nursing home. You can borrow and tweak their policy and their disinfection and their cleaning and all their housekeeping policies specific to COVID-19, and just tweak them, making them appropriate for your program. We want to really take a look at, we know tables and chairs and doors and doorknobs, but handrails, light switches, phones, computers, keyboards, copy machine, fax machine, and include charts. Dawn had mentioned that the medical records, we all use and keep going back and forth to, but it wasn't until someone had like a rude awakening and thinking, oh my God, we didn't disinfect the charts, the outside. So we really need to take a look at everything that's on the list and everything that's off the list that we have not yet thought about, but we need to think about as we're putting into place all these parameters. Ensure that the adequate supplies and equipment are maintained and stored so that we don't have to share things, so that once they are cleaned, they stay that way until used again. We want to make sure that all of these things are in place. Okay, let's look at recreation. So with recreation, we have to evaluate again the seating plans for the activities and the use of the PPE. So someone had asked during Dawn's session, does recreation need to have masks? Does recreation need to have face shields? And the answer is not a given. It's really determined by the level of registrant compliance, the type of activity, and the assessed level of registrants. What are their behaviors? What are their actions? What are their limitations? What are their strengths? Knowing our people as we do, knowing their level of compliance and the type of activity, and then the closeness involved should determine what type of PPE you use. That's why it's important that you have that supply and that inventory there, because if you need it, you need to have it. Consider devising separate activity kits labeled with each participating registrant's name to avoid multiple people touching the same items. It's really important if there's a way that you can do that. You can do that with crayons, with colored pencils. Maybe even you could have bingo chips that are for two people who are together all the time, or that you don't use that at all. But it's really important when you're looking at your activities, thinking about how to use them, where to store them, and how to clean them. Think about those musical instruments that we need to think about under any other normal circumstances. Playing cards that are going back and forth, crayons, colored pencils, bingo chips. All of these different things that we think about under normal circumstances, now we have to intensify our thought process and our sanitizing and maybe changing, maybe doing more word games, maybe doing more things that we could talk about and see on boards. And then how do we reach the people who are vision impaired and hearing impaired and all the different impairments that we deal with our people all the time. Consider the safe use of patios, courtyards, any kind of outdoor activities that are safe. Maybe we can try to encourage that, obviously during good weather. And then the need to follow up and make sure that we do the necessary cleaning and disinfecting for all of that. So once again, I know when people using the musical instruments, and then we have someone using a kazoo and using bells, and whether they're handling it and then putting fingers in their mouth, or whether they are using it now to put in their mouth. Well, we need to rethink, obviously, not use these things, and what we do use, how to clean, sanitize, and disinfect. Okay, let's take a look at rendering personal care. So you have to develop a plan, and we're, taking a look at our ADLs. We're taking a look at the toileting and feeding, and how do we accommodate the needs and the privacy of the registrants while at the same time maintaining social distance. Making sure that we are using appropriately the PPE, the equipment for us and for the registrants. And then when it becomes difficult for them to use, especially during some type of treatment, then what are we putting into place to keep the best distance possible, and to one of us be wearing the mask at least as a minimum? Again, we need to think about the ADLs and the activities that we're providing, and maybe what we shouldn't be providing. Are you doing showers? Is it a safe place to do showers? How are you doing them? What are you using to do them? And then what about your linen and your towels? And how often are they getting cleaned? And do you have a good par inventory level for those things as well? So it's so much to obviously consider. Now, once you're taking a look at all that, there is some general strategies to continue. So, and to consider, because it's not only about maintaining things to open, but now we want to maintain an ongoing operation of the program. So let's take a look at documentation, our favorite subject. Obviously, when we are opening, we have to open as though each person is a brand new admission or a brand new readmit. And so everyone's got to be assessed, and all the things that we need to put into place prior to them opening, their diet order, their physician order, their rehab orders, any lab work, anything that we need to know, their medications, what can we do? Can we be administering the medications? All the different things that we would look at, the UAS, the psychosocial, all the things that we would be putting into place under any circumstances based upon our 425 and the 415 code we have to adhere to. Then in addition to that, you're going to look at any telehealth needs and ensure that telehealth care plans are incorporated in the medical record. Have to make sure that that is all there in place, and that care plans are updated to now reflect the current status of the registrant, making sure that everything on the care plan relates to the individual, to their preferences, and at the same time adhering to regulations, but can make sure that those care plans are what we're doing, that staff knows what we're doing. Everything we put into place, staff needs to know about. Developing policy and procedures. We know what we had to have for our 425 code. Now we need to have so much more to be sure that we are following what we need to do for the COVID environment, what we need to do to adhere to DOH and CMS guidance, and to any governmental orders. I am wanting to be sure that everybody goes back to that documentation, and I truly, truly know how many details have to be looked at and paid attention to now, but the documentation cannot take a back seat. We really need to, more than ever, not just about compliance, but about assuring that all the practices, all the policies, all the procedures that we are now creating and developing and communicating to families must be in place and clear to staff. All documentation needs to be updated and relevant for each individual registrant during this time, obviously. Then you want to create a process to be used for screening. So now this is a different type of documentation. It's not in the medical record, but the screening questions. Who is going to ask each of the staff members when they come in? Who's going to ask those questions? Who's going to ask the registrants the questions? Where is it going to be done? When is it going to be done? Who's going to be taking the temperature? Who, where, and when? It's like these questions we have to keep asking ourselves over and over, and we have to maintain our practice and policies and procedures, but also we have to maintain records that all of this is being done. Checking out who gets tested, where, when, with what frequency. And then what happens if a registrant or a staff member tests positive? What's the procedure we follow? Who do we notify? How often is it done? How do we get outcomes and down the road results? And then to whom do we communicate that to? Do we communicate also to the Department of Health? So you would go to your administrator and ensure how that is being done. But there are things that we need to look at, not just that we have to have these things into place, but who is doing it, where are they doing it, and when are they doing it? And then agreement between the registrant or representative and staff reflecting an understanding for family backup that if a registrant cannot be admitted, that they need to be sent home. Who's going to be there? We have to make sure that all of these things are in place. And the reason that it is under documentation is because it's not only about policy and procedures, but it is also about keeping records. Let's look at staff training. So this is important because we want to make sure that no one says, I didn't know that. We want to make sure that everything that we are thinking and planning to put into place is actually shared and known and understood and accepted by staff. So they need to know how to use the PPE and how to remove it effectively and safely. They need to know what we have to do about housekeeping, cleaning, disinfecting, and the storage. What about infection control? I know a lot of people have said that, you know what, we know infection control. We didn't need COVID to put that into place. We're really careful. Well, but now it's a new environment. It's a COVID-19. And so whatever we were thinking was in place, we need to really put into place and make sure that staff knows it. I really recommend that all of these things come under the heading of your in-services and that you have attendance sheets. And that the attendance sheet doesn't only say the date that they were in service, what the in-service is entitled and the content and the bullets of it, but also that a statement, not that they're signing it, but that they are signing that they understand that what is imparted, they understand and agree to. That's a very important piece. And then reporting mechanisms. To whom do you report whatever you see? Is it your supervisor? Is it the program director? Who's going to be in staff? And then where does the program director report this information to? To the administrator, to the CFO? Would they go directly to the Department of Health, or is there a protocol that they don't go directly to the health, but that they go to their administrator? So again, that reporting mechanism should be understood by everyone. And then any new policy and procedures, any new protocols that were developed specifically for this time, specifically to allow us to open, specifically to keep us in ongoing compliance, then all of these policy and procedures should be reviewed intensely with all the staff, and they should sign off on that they have received the information, they understand it, and will comply and accept it. Okay. Now, let's take a look at some more strategies to consider is protocols. So in addition to the protocols and the policies that have been mentioned, there's some other things to take a look at. Like, for example, what do you do about transferring the registrant to the emergency department? How is that happening? Who is taking them? Who is meeting them? Will someone be meeting them? Is there someone who can even go in the hospital with them? Will that even be allowed? There are all these factors to consider. Previously, you know, we dialed 911, we notified the family, we arranged for transportation to take them, and we were good. Now we have to really look at all the other components to ensure that we are doing what we're even allowed to do, to making sure that families are knowing what is expected of them during this time. What do we do if a registrant or a staff person refuses screening? Now, you may not be able to mandate that they accept the screening, but you can certainly mandate that you have a policy in place that failure to do that will result in them not being admitted to program. Because once again, that would come under the kind of heading where you would say that a person, a registrant or a staff member, is being a danger to themselves or others. And the others is very important because sometimes you might find someone saying, listen, I don't want to do it and I'm not worried. If I catch it, I'll be fine. Well, the question clearly is we don't want everybody else to catch it. And so what do we have to do? We have to have a protocol in place and we have to be sharing it with staff and families. Okay. What actions to take if a registrant, staff, driver, matron, anyone, an essential vendor coming in refuses to wear a mask? What are you going to do? And, you know, some people will say, well, as long as they're 6 feet apart, well, I'm sure that the state is taking a look and saying, you know what, you never know if a registrant is going to fall and you need to be right there with them and you cannot be socially distant. You have to have that mask. So if you are thinking that they have to do this when you have determined it to be appropriate, and if they are refusing, once again, you have to have that protocol in place, shared with every pertinent person and agreed to. What about a protocol for people returning to work, but what they're saying PUI, person under investigation? Maybe they had symptoms and they haven't taken the test yet, or they've taken the test. Don't know what that was. They don't know what has occurred. They don't have the information yet, but they are pending results, pending outcomes. So what are you doing? Are you not taking them in program during this time because you don't know that in fact they are safe? What is the protocol and with whom is it shared? All pertinent people. What about, just as a thought, maybe you want to do something to memorialize registrants who passed away during this time, whether it be from COVID-19, whether it be from something totally different. How about taking a look at the registrants? What might you want to do as a memorial? What might you want to do to even bring into place some other things, like discussing some of the trauma that they experienced, discussing what they went through during the 3 months? What are the protocols that you want to put into place? And at least if you don't have a given, you don't know for a fact which way you want to do it, it's interesting to at least think about it and decide maybe we do want to do it. And if so, how do we involve staff in it? How do we involve the registrants in it? What would be the most effective way for everyone concerned? Okay, so those would be the protocols. And with your person under investigation, you know, you're taking a look at whether they have fever, whether they have traveled. If they didn't pass the screening, then they may also be under investigation. Or if they took the test and we didn't find out the results and we are awaiting, or if they were out of the country and then they haven't done it. All of these things is part of the screening. All of these things is part of the person under investigation, is really critical to whether we allow them to return to work at all. And then we take a look at quality assurance. So during this time, we should really have audit tools in place that are, and clearly a process to evaluate the ongoing effectiveness of everything we are putting in place. You know, we're looking to create all these policies and all these procedures and all these protocols. We're looking at the environment. We're looking at everything that we're setting up. And now we're thinking we're doing it all perfectly well. And now we have to really look at it. Are we evaluating it and determining, is it effective? Is there another way that we could tweak something or modify it or change it completely or eliminate it to make sure that we are doing everything to keep our registrants and staff safe? We should be looking at specific audits for infection control. What about adherence to CMS guidelines and DOH guidelines? What about the telehealth? What about our documentation? Everything that we're doing, all the encounters, follow-ups that you're dealing with family, follow-ups with physicians, follow-up with pharmacy, follow-up with all the different areas. Are we maintaining documentation and recording our encounters? And through all of this, we need to maintain confidentiality. We all know about HIPAA. And now, while we all know about it, we all need to make sure that, in fact, with everything that we're doing, we are maintaining and keeping their confidentiality intact. And that goes to the staff confidentiality as well. Okay, so now what I did is I created an Excel spreadsheet, which will be within your handouts. It will be given to you with the handouts. I call it an accountability chart. It is not quite a to-do list, but it can be certainly looked at that. But the purpose of this accountability chart is to list all the different things that need to be in place, and then develop a list of who is doing what, by when, and how are we monitoring that this is happening. So if we take a look at this accountability chart, what I did is I made the 4 columns: the task, the responsible party, the due date, and the status update. And this can be an ongoing chart. So for example, all the different components, all the different aspects, characteristics that I mentioned in the webinar, now we take a look at PPE. And under it, what I would suggest on the Excel spreadsheet is that you put bullets. You can put the bullets that I have in the guidelines. You can add your own. You can modify it. But this way, under each PPE, you could have, for example, checking inventory, evaluating the needs, ordering. Was a policy and procedure put into place? Was it developed? Are expenses being tracked? So those are the A through E that I have in my outline that I shared with you. You can take any or all of those components and bullet them under the category PPE, and then assign a person, not a discipline. You assign a specific person who is going to be responsible for doing that task, and by when is that task to be completed. So you may have someone checking the inventory and placing an order. And so you will have, Gail is doing that by this date. But then once that is done, you may change that to evaluating the par level. So in other words, this is an ongoing fluid chart that makes sure that all the things that need to be implemented are implemented. And then once implemented, what do we need to do? What bullets, what components, what do we need to do to follow up on each of those different things? So you're going to have the task with all the bullets listed underneath, the responsible individual, the name of the individual for each specific task, the due date by which it should be completed, and then the status update should really be either determined by the program director, because it should be reported to them, with the understanding that if you are giving someone a week's notice, so then in 1 week, you could put the status update date down. Understanding that if any staff member is having difficulty completing any of the assignments, then they need to come and give you a status update before that due date, so that if it's important that it be achieved, you can all do what's necessary to facilitate and expedite its completed outcome. Okay, so for example, if we take a look at staffing, so you may have the bullet under there, determine who, which staff, and which disciplines expect to return. Who is doing that, and by when? Now, some of these things will be achieved, and then they could be removed from the list and other things being added. Some of the things may be achieved initially, but now we want to give a different due date to make sure that it is done on an ongoing basis. I have found doing this accountability chart extremely successful. I've used it in many different ways for many different programs. And it is a way to make sure that what you're hoping gets done doesn't fall between the cracks. It also makes sure that the person who is assigned knows that they are assigned to do it, and there is no confusion as to, oh, I thought it was another person. And then the due date, which is clearly developed so that it meets the necessary guidelines, whether it be for opening, whether it be for their safety, whether it be for compliance. But everyone has to know that if something comes into play, things do happen in life, we all know. So if something comes into play that prevents them from completing this or completing it in a timely fashion, they need to go to you beforehand so that you can make sure, if it's important, that you do what's necessary to meet that due date. And if it's not so necessary, well, then you can change the due date and extend it. But I have found, and I put down all the different components, all the different pieces that were listed in my outline, I have listed here on the accountability chart. When it is given to you, it will be given on the Excel spreadsheet. So you can add and put in any of the bullets, whether they be from my outline or whether they be from your own considerations. And so it is a great tool for accountability. It is a great tool to get you going. It is a great tool to minimize, at least reduce some of the overwhelm, some of the confusion, because this kind of puts everything together and who's doing what by when. And so everyone on the team. And this is the important piece. I'd like to stress so many times, I know that program directors think that they have to make it happen. They'll include some other people and they'll do some other tasks, but they really have to make it happen. And I would like to stress the importance that it is the team who are the only people who can make this happen. Without the team involvement, this is way too much for any one person to even consider doing. And this way, you have the team morale, you have the teamwork, you have all the different aspects that were discussed in the teamwork webinar. And it's important that everyone be together, because once they develop all of this together and complete it all together, there's a real buy-in and everyone is then in on it together. And so that is the way that I take a look at it. And I have shared this now with you. I can open it up, and Anne, I'll turn it over to you, or how you may want to do. I know that there are a bunch of questions.
Thanks, Gail. Jeff, if you are there, can you just remind people how to submit their question? And
Absolutely.
Gail and I will tag team and answer together.
All right. If anybody does have any other questions to submit, you can do so through the Q&A button in your webinar controls. And we've gotten a few of those that I'll be happy to read off now.
Thanks.
Let's see. Is there any indication as to whether MLTCs will be required to reissue authorizations that were suspended due to COVID?
That's a great question. We've already spoken to DOH about this. We share that concern, and we're advocating for authorizations to resume at the level that they were prior to the state of emergency.
Is there a possibility of having MLTCs authorize and reimburse for telehealth visits?
That is currently happening already. Many plans are have authorized and have paid providers for telehealth.
We're hearing that many of the testing results are provided via a phone call. How do we obtain proof of staff, agency staff, and registrants' test results?
So they probably don't need that. The testing agency probably doesn't know that they need more than just a verbal report about the test results. Laboratory results are required to be given in writing or electronically if the person requests it. So the person who is, if it's a registrant or a staff that is being tested, they have to request written documentation from the test center when they have it done. So, we believe that a verbal, communicating verbally won't be sufficient for DOH. And so the registrant or the staff person who's getting tested in the community must request that their results come back in writing.
Isn't it the transportation company's responsibility to know how to use and what to use in regards to PPE and cleaning their vehicles, since they're paid by Medicaid?
Yes, absolutely. The only caveat there, or the only clarification, is that if you have your own vehicles and your drivers are staff, you would be required to maintain that. But yes, of course, if it's the vendor with which you contract is responsible for following the CDC guidelines for cleaning and the vehicles, and providing their own PPE or just masks for their own drivers. Do you have anything else you want to add, Gail?
Yes, the only thing that I'd like to add to that is that you want to make sure, we certainly know that they know what to do, but sharing with them those expectations when you're first reopening is just, again, reiterating. And so that's important rather than make that assumption. And the other piece is that it could be part of your QA. You just want to make sure that what you know is has been in place, continues to be in place.
Thanks, Gail.
Do they want us to wait for results prior to coming back for registrants? And how long prior to opening, as we can do that soon? These people are in the community, so they can be exposed at any time.
Yeah, that's a great question. We don't have clarification on that. We are hoping to get something more concrete from DOH, and I would expect DOH would give that to us. They would want to, I expect them to give guidance that, of the time period that a registrant has to be tested and get that test result prior to coming into program. So they might want it within a week. I'm not sure, but once you get that test result, you would be responsible for screening when that person comes back into program every day. So all I can tell you at this point is that DOH is going to require registrants to have a baseline COVID test and have that be negative prior to coming back to program. So I don't know the time frame by which they would get that test and get the test result, and then them actually coming into program. That's going to have to be coordinated.
If staff are required to be tested weekly, who pays for that? Would it be insurance or the responsibility of the adult day healthcare program?
That's a good question. We are, we've been following this test, or the, staff testing very closely through the nursing home and through our connection with Leading Age New York. And so we know that there's been a lot of issues around staff testing. We know that some insurances will not cover test staffing. So private insurance anyways. So a lot of nursing homes are doing their own testing in-house for the staff. That's one possibility. The other possibility or potential for staff to get tested is through the free like drive-in testing sites in your community. Again, that's free. They don't ask for your insurance information when you pull up. Keep in mind you have to ask for written documentation of the test results, not just a phone call. So who pays for it? Typically right now, how it works in the nursing home, for the most part, it's the nursing home that is paying for it. So you should coordinate with your nursing home and give them the heads up that you're planning for reopening your program. You have X amount of staff that will need to be tested once per week per DOH order, and that the nursing home has to kind of fold that into the budget. It's really important that you, as Gail said right off the bat, I think it was like the first Roman numeral about keeping track of the testing and keeping track of the cost of how much you are, everything, all of the costs associated with reopening and testing, because we are working really hard on the nursing home side and obviously on the adult day healthcare program side to get reimbursement for your facility for the staff testing. We know that FEMA is, that there's a good possibility that FEMA will reimburse nursing homes. And so the nursing home has to be sure to include the adult day healthcare into their reimbursement through FEMA. So there are a lot of moving parts here. It's really clear to have an open discussion to communicate clearly to your nursing home administrator what's expected and to come up with a plan of how we're going to pay for it and how these tests are going to happen, either through the nursing home system or through community testing, which is free. Thanks, Jeff.
How often does the registrant have to be tested if they attend the program 5 days a week?
We're unsure about that. We don't know if at this point, all we know is that there needs to be some kind of baseline test, and they have to test negative prior to coming back to your program. We are unsure at this point if DOH will mandate a test every 6 months, during continued stay. All we know is that they're expecting registrants to be COVID-free when they come back to program. And if there's anything more, or as we learn more, we will be sure to communicate that.
But at least the best thing we should be doing is recording that we're doing the screening every single day. We're taking the temperature every single day, and if we're not seeing symptoms, then that's at least a good thing.
Thank you.
This person's looking for some clarification on the readmission of registrants when we reopen. They were not discharged when we closed. Did you mean we will need all updated paperwork as if they were being readmitted?
Yes, you need to have all new information because they have been gone for 3 months. So we have no idea what the status is, what the functional status, what their abilities, limitations. We don't know any of that information other than the little that we may have gathered through the telehealth. So yes, we need to have them come in, and we know about the being tested, but we have to do the whole admission process. And I understand that if you're admitting hypothetically 15 people on one day, and then it looks like, okay, so now care plans and progress notes and everything else is due at the same time, but it doesn't have to be, because it's like when you open a program right from the get-go. So everyone comes in on day one, but then you stagger those notes. You can't be late, but you can always be early. So instead of doing a quarterly 3 months. So you may do it in a month and then do in other people and stagger it. And then ultimately you'll have everybody on their regular different pattern, and not everyone will be due at the same time.
Will the capacity decrease correlate with 425.1D?
Yeah, so that regulation is operating hours for adult day healthcare, and our regulations say that each adult day healthcare session must operate for a minimum of 5 hours. Right below that is 425.1E, which talks about the visit and a 5-hour rule. So yes, we are concerned about, you know, diminished capacity or decreased capacity, or operating at a decreased capacity for a period of time, and how we can perhaps stagger arrivals and departures, and do that in a way that, you know, either follows the 5-hour rule, or, you know, what we're advocating for, and I think what would be most helpful for everybody is to have that 5-hour rule waived for a period of time, so you can keep people kind of staggered, or this, you know, arrivals and departures, so you can maintain a reduced capacity during the day, but you can actually bill closer to your full capacity.
What is the protocol for sending a registrant to the ER? What is different? What should the caregiver do?
You know, we're not 100% sure people can go into the hospital with them. Based upon what the regulations are at that time, I don't know whether they can be met by a family member, whether our transportation or whether an ambulance would be taking them. My guess is that if they were going to the ER, we would call for an ambulance, paramedics to take them. I don't know. We can't tell you at this time whether they will allow someone in with that registrant, or whether we just have to notify the family members and then they have to take it from there, with us, of course, being in the loop so that we know what's going on. But I don't have a definitive response to that because we really don't have enough of that information yet.
I would just add that if somebody is suspected of COVID, so they have, you know, they're coming in and you screen them and they've got a temperature, you know, you need to isolate that person immediately, call the family, and the family's responsible for picking them up. And at that point, the family can call the PCP or make an appointment with the PCP, or if it's an emergency situation, the family would be responsible for taking them to the emergency room. Or, you know, the program can call, you know, an ambulance, but that person should be isolated. You know, the person doing the screening should be in full don PPE. So I believe that, I hope that answers the question, and if it doesn't, please send me an email.
And that's one of the things that I did mention about having an isolation area, and also communicating with families prior to opening exactly what are the expectations we have of them, so that in the event that a person came into program and became ill, or was first arriving and then didn't pass the screening, or the question might even be, in some cases, you're going to have the screening done by transportation people, but the temperature being taken by the program staff. So whatever process you put into place has to be communicated to the family so that they know exactly what is being expected of them.
There are many people who cannot answer how they're feeling. Will we be able to take the word of the family care provider?
I would think that you would do it as though it was the person's representative. So I would think the answer should be yes.
Did you say the drivers have to be tested?
Drivers only need to be tested if they are on your staff. So if they are considered adult day healthcare staff or nursing home staff, then they would fall under the once per week testing mandate. And keep in mind, it's June 25th, and that is the regulation or the requirement right now. So this could all change. But if it's a contracted vendor, or if you're a Method 2 program, at this time, to our knowledge, no, contracted drivers do not need to be tested. They do, however, need to be screened, just like how I'm screened every morning before I come into work. So they do need to be screened, but no, they do not need to be tested.
Unless you're having them come into the program, and then that would be a different story. That's why I had said, you know, instead have staff meet the registrants at the bus and the van, so that your people do not come in, so that the drivers and matrons do not come in.
Great. Thanks, Gail.
Please speak to the staggering of shifts you mentioned earlier. Is DOH going to allow us to have registrants in program for less than 5 hours, or change our times of shifts?
Yeah, so that is just one, staggering the arrivals and departures of registrants is just one idea, one example of program operations that you could, you know, as operating at a reduced capacity. So we are advocating for flexibility in that, obviously, that we would need a relaxation, or the 5-hour rule would need to be on hold for a period of time. But staggering, you know, having somebody come in from 8 to 11 or 8 to noon, perhaps, would be, you know, a wave of registrants, and then another wave would come in from 1 to 4. That's just one example of how you could perhaps stagger your program. DOH right now, they're not really getting into the weeds of program operations. They are more concerned, and the conversations that we're having are more about staff testing, PPE, registrant baseline tests, and we feel that we can really support our argument by saying that it's in the best interest of the registrants, it's for the safety of the registrants that we have a reduced schedule, or they're in the program for you know, 4 hours or less than 5 hours, and we just feel that this is a safety issue, and that will we're very hopeful that DOH will give us that flexibility.
Do we have to create new charts and ID numbers, or continue with old charts?
I don't see any reason to have to create a new chart. You can do it like a readmission. And I think, but although you need all the new information to be put in, but there can be, you know, you can have a protocol that is very clear that on March, whatever it is, March 19th, March 17th, whatever the date is that you officially closed, that everyone knows that that program has been on hold. So that's why you didn't do a discharge. So it becomes a readmit. And you can have a policy that just says that all people who were not in attendance during the COVID close down have been now readmitted with all pertinent information coming with them. Does that answer the question, I'm hoping?
If we obtain an order for testing for COVID-19, can we test our registrants ourselves? How many registrants will be allowed at any one time? If registrants are wearing masks on the buses, will we still limit how many are allowed on the bus? Can our PPE be stored at the nursing home, or does it have to be on site at ADHC?
Okay, that's a lot of questions. So don't dismiss that question yet, Jeff, because I might have to ask you to re-answer or re-ask it. Oh my gosh, I don't know where to begin. So yeah, the PPE can be, there are a lot of unknowns. Okay, and forgive me for making some assumptions here, but I feel if you are on site with the nursing home, you know, your PPE can be stored with all the other nursing home PPE. And you know, and if you're on site with the nursing home, I don't see any reason why your adult day healthcare staff can't just get tested in your nursing home. I don't think you should be, you know, I don't think you need to do your own staff testing in your program if you share the same building or if you're on the campus of the nursing home. If you're off campus of the nursing home, then that's, you know, that's a different story. And we would have to get some permission from DOH to, you know, you'd have to get test kits. It's a whole thing. And we would have to get some clarification from DOH if they want you to do that there. What were some of, Jeff, can you ask some of those other questions again?
Sure. If we obtain an order for testing, can we test our registrants ourselves?
Yeah.
How many will be allowed at any one time?
Yeah, we're not sure how many registrants will be allowed at any one time. We just know that DOH is concerned about that and has told us that they want to dramatically reduce capacity for a period of time. Is that it, Jeff?
Yes. For those programs who had less support from upper leadership prior to the pandemic, are there any talking points to advocate for reopening within our organizations? I'm concerned that implementing these necessary protocols will be a great disincentive from that administrative vantage point to reopening.
Sure. If people feel that way, they should contact me and we can work it through. I think every program is a little bit different, and some talking points that might work for you might not work for others. So if there are people out there who feel that way, please contact me directly and we can approach it. We'll approach it on a case-by-case basis.
As of now, are there DOH guidelines as to how many registrants can be transported in one vehicle? Or if arrival times can be flexible due to having to make multiple trips?
Well, right now there's still a prohibition on restriction on multi-loaded vehicles. So that's number one. We have to get that that policy reversed, or that has to expire. So no, at this point we don't have any idea about the capacity on the vehicles or limited capacity on the vehicles. But our message to the state and what we're hoping, as long as an individual can wear a mask on that vehicle, that there doesn't necessarily need to be 6 feet or reduced capacity on that vehicle. That we need to, as long as somebody can ensure that they can wear a mask, then you can load up the vehicle. This might be this might be a different policy or each vendor might have their own policy on this. Of course, DOH might have their own policy and guidance on this. We're still in the works, but we're advocating for registrants to wear masks and on the vehicle if they can't ensure 6 feet distance. Gail, do you have anything else you want to add?
No, the only thing that I would add to that is that if a person has the mask on, but that there's a good likelihood of them removing it, then the plans have to change. So I think the answer is, your answer is right on, but depending upon who the registrant is and what they may or may not do, may change that policy.
Is a new UAS for every registrant returning to program going to be required as if they were a new admission?
Sure. It is, they are for all practical purposes a new admission. You know them from having been there before, but they haven't been with you in 3 months. So yes, they need to be reassessed, and they need to have a UAS upon coming in.
And keep in mind that the reassessment now is much different than it was a few months ago, right? So the reassessment, there's no longer that preloaded reassessment. So it kind of serves, even if it's a initial assessment or a reassessment, the questions are going to be the same, and you'll have to answer them answer all of the questions. They won't be preloaded.
How soon do you anticipate programs opening?
Well, I wish I knew. Again, it's our number one priority. It's the number one thing that we're working on to get programs reopened, and to prepare you for that, and to prepare the registrants for that. I wish I knew. I really don't have, this all depends on DOH and what they are comfortable with. We make the argument every day that, registrants are safest in the adult day healthcare program, and that programs are ready to open. At this point, I don't know, but we are absolutely advocating for adult day healthcare programs to reopen this summer, and as soon as possible.
Do we think weekly testing will go on indefinitely, or at some point do we think the frequency will be decreased?
Well, that's a really good question. Well, it's already been decreased once, so that's good, right? So we were advocating, and this is, keep in mind, we're just talking about adult day healthcare staff need to be tested once per week. And nursing home staff. So it used to be for the nursing home twice per week. And there was a lot of advocacy done on provider associations. So I really can't speculate if that's going to go down or be eliminated altogether. I can just say that for right now, DOH will be expecting all adult day healthcare staff to be tested once per week.
Can we start obtaining orders now for readmission?
I don't know. I'm gonna have to think about that. I don't have.
Yeah, you know what? If we're saying that it has to be 6 weeks prior to, and we really don't have a date of when they're opening, I don't know. I think I would maybe hold off a little bit. I think we could talk about it, getting them thinking about it, but I'm not sure that the orders would still work if it's longer than we would hope.
Yeah, I don't know. I would wait until we get a more definitive answer about when programs will open. But Gail, you're absolutely right. There's nothing to prevent you from starting that communication with physician offices or with your registrants, like letting them know that we're going to be scheduling a doctor's appointment for you to get new orders and to get tested, just to kind of give them a heads up that they're going to have to meet with their PCP.
How can I request a new admission process which includes a physical exam when most clients do not want to go to the doctor's office and offices do not want elderly clients in if they're not sick at this time with increased cases?
I think that when we're talking about if they're not sick, then there's a lot of things. I think the physician would see them. I really do, based upon it not happening yet. And so we still have some weeks to go before they would have to make that appointment. And I think that if they are free of symptoms and we have been in touch with, we may need to start the contact with the physicians and let them know, or the families at least should start the contact with their primary physicians and let them know that this is what we're hoping and this is what we're going to need your approval for, including the order for the person to be tested. I actually think that the same like we were talking to families to get them going, I think we should talk to the families about starting the conversation with the primary care physician so that we can make that happen and that they are at least aware of it up front before they absolutely need to do it.
I 100% agree with you with what you just said, Gail. And I would just add that from my personal experiences with, going to a physician, the physicians aren't turning away business for well checks or for physicals that, and this is required for treatment for adult day healthcare. So it's one thing if the registrant feels uncomfortable going to the physician office, in which case, Gail, you're right, you should start that communication and get them, kind of warm them up to the idea. But I don't think there's going to be any issue on the physician end to see,
Right.
a registrant who is not exhibiting any symptoms.
Several people have mentioned not wanting to return, and 2 have mentioned disenrolling. We've told them that we are temporarily closed right now so that they wouldn't be able to come in and sign discharge paperwork. Should we be mailing that to them if they want to discharge? For now, we've offered to continue telehealth and meal delivery until reopening, and they are agreeable. I just want to make sure I'm not doing anything non-compliant by continuing to serve them with consent.
As long as they're not discharged, you can certainly continue with their consent to provide the telehealth services. So I would not even consider discharging at this point, because who knows, whatever they're thinking, they may very well change their mind, and depending upon our timeframes, it may all work out differently. So I would continue providing the necessary telehealth services, keeping your records of it, and then wait to decide what to do once the actual reopening plan is put into place.
If in-services were done with nursing home, do we need to still have separate sign-in for ADHC?
I think if the in-services were done that could absolutely relate to your adult day healthcare staff, and I think that if they have signed that they were there and that they understand it, then no, those specific ones would not need to be. But I would want to make sure that whatever the in-service was that they attended, that it was not when they were just working with the nursing home during COVID, furlough time, but that it was something very pertinent to and specifically tweaked to the adult day healthcare.
Is the plan to open on-site programs and off-site programs at the same time, or will off-site programs be open first?
Well, we don't know for sure, but DOH has told us, or has implied that they feel that they would like to open off-site programs first and have a trial period before on-site or campus-based programs open. So that's just based on what they've told us. It's not, nothing is set in stone. It hasn't been written or disseminated to anybody yet, but that is what that's what they've told us, that they prefer off-site programs to open first.
This person's asking, this refers to the question Gail answered regarding coping with reopening paperwork. Can you suggest some tips for what to do during opening week?
if you mean opening week, meaning the documentation piece, then everybody would need to have it the same way that you would typically do. The only thing is then down the road after that, you would look within the month, each month you would stagger the documentation for each person so that some of the people will have it 1 month, a quarterly, so to speak, in 1 month, somebody else in 2 months, and then other people in 3 months, so that it'll all be within the allotted time frame.
If clients live together in a group home, can they all ride together?
Yes, right now they can, I mean, yes. So the letter, and actually I have it right here, for transportation. So right now, if individuals who reside in the same home, you are allowed to multi-load your vehicles. You are allowed, if perhaps they are going to one physician office, or so Medicaid will allow individuals who reside in the same home to be transported by one vehicle. And obviously we are we're working with DOH to lift that mandate or that restriction on multi-loaded vehicles. So moving forward, when your programs reopen, both individuals who reside in the same home and individuals who reside in different homes will be able to, be transported on one vehicle.
We all know that people with dementia are very often not capable of compliance. Do you feel that DOH would benefit from being provided with case examples of the unique needs or capacity to comply for people with dementia?
I think that when it comes to the dementia, I think that the Department of Health is aware, and I think that as part of the proposal that Anne had sent in, I think that they try to talk about the different populations and their needs. So I'm not so sure that it's a necessity to spell that out. I think that as Anne has her actual conferences with them, then those things come out verbalizing, being verbalized.
Yeah, I mean, they understand our population, and they understand people with dementia. They've been trying to work with nursing homes, people who have dementia who live in a nursing home. So I think they understand the nuances or the difficulties surrounding long-term care and providing that care to people with dementia. If there is something specific that you have a concern about, or you would like DOH to be aware of, just shoot me an email, and perhaps we can bring it up. But at this time, DOH is less worried about, that's kind of a very detailed question. They're really focused on the broader safety issues of registrants. So if you have some specific concerns about people with dementia, just send me an email, please.
Should we be obtaining doctor's orders for telehealth?
No orders were ever required for telehealth.
Do clients have to distance at program if they reside together?
I think if they're a husband and wife, and they're living together, then the two with each other don't have to, but they certainly do with everyone else. So I think the question is, if the two of them are alone, no. If the two of them are interacting with other people, then yes.
Yeah, I don't know how. I think that would be really hard to implement. I think you just need to treat everybody, because they're all interacting with each other. So if you can't maintain 6 feet distance, then, we need to encourage all registrants to wear a mask. So I don't know if that, unless you have like a separate program space and you can put everybody in one adult home or group home in one section or area. I mean, as you said, as Gail said, I think even those people would probably need to wear a mask.
Are matrons required on the vehicle if we have our own transportation and drivers cannot take their eyes off the road to monitor if registrants have removed their mask?
Matrons are determined, whether you use matrons or not, it's really determined by the program. When you set up your transportation, whether it's a contract with a vendor or however you do it, you really determine what that need is. That's not a mandate from anyone else other than what your contractual arrangement is.
That's correct. There's no requirement for matrons from the state level.
How much time do you anticipate we'll have to prepare for the opening once we've been given a tentative date?
I think that you should start now. I think that there is some things that you can do immediately and begin your Excel spreadsheet, taking a look at all the different things you have to look at. You could start your environment, you could start your policy and procedures and protocols. You can begin immediately talking to your managed care. You talk to your families and they can give a head start with their primary care physicians. I would put a lot of those things that are not time-based, but could take a lot of time that might prevent you from having them come in. That's what I would start to do now.
Please clarify. You mentioned staggering the paperwork for readmission of all the registrants when we reopen. But if we're discharging and readmitting all registrants on the UAS, we cannot bill until the registrant's UAS is complete, correct? So the amount of registrants that can come in will be dramatically reduced, and we will not even be able to bill all of them right away.
So that's, okay, so it's a rule of thumb. Everybody knows that you are not allowed to bill for that first visit until the UAS is complete. So yes, that's correct. And we do know that DOH is going to, we don't know the number, but we do know that they're going to dramatically reduce the capacity. So what we mean by staggering or what we mean by changing the paperwork is that once you get that initial UAS complete, then this is what you need to do to plan for reopening, right? This is the whole, we have to you have to come up with a process as to who's coming back, when they're coming back, how they're coming back into your program, and which days, so you can plan for doing the UAS on those people for that day in order for you to bill for that visit. And then you can kind of, for that first wave, perhaps you do the UAS, get all their paperwork in, and then, you can always do the UAS sooner than 6 months. So you can kind of start to build some space or kind of spread out the UAS for the reassessment. But yeah, it's going to be a lot of work, and it's going to take a lot of planning to plan who is coming back to your program and on which days, and how you can plan to do that UAS, how you can get that finished. Gail, do you have anything you want to add?
Nope. I just want to wish everyone a lot of luck, because I know how much work is involved, and just for them to keep remembering that you need to work with your staff, with your team, use each other as support systems to help make it all happen. And it absolutely will happen. It can happen. It's like starting from scratch, and we all did that, and we all made it happen in the end. It's just that it is a difficult time now. So just keep in thinking that this is not about a one or two people making it happen. It's really the team.
Has DOH approved any of the waivers the Adult Day Healthcare Council has asked for?
Well, DOH hasn't approved anything yet. So, I mean, they haven't, everything is still just being discussed. And so there haven't been any approvals. There haven't been any concrete decisions that have been shared with us. We have had multiple conversations with DOH, and they have given us some clues as to what they're expecting. For example, like reducing your capacity for a period of time, or allowing offsite programs to open first. But no, nothing has been absolutely set in stone yet or decided, and that includes maybe a waiver of the 5-hour rule.
Please clarify, are we actually readmitting each registrant, or are we treating them as an admission in that we will get orders, do an assessment, and UAS if required? Has DOH stated that we must discharge and readmit?
I don't think there's been any message about that at all. I don't think that DOH is even looking at those details. I think that some of the programs have policies where they discharged a person if they were going to be on vacation for 2 and 3 months. I think right now this is different. It wasn't about vacation. So I think if you have that protocol on hold that talks about that the program is temporarily closed due to state of emergency, COVID pandemic, then how you make those plans in terms of, yes, you're readmitting, but whether you have to go through a complete new chart and a new ID number, I don't think that that's necessary.
That's correct. We're not talking, people are not discharged. They're still on your roster. They're not discharged from the program. When we say, like, go through the admission process, we're talking about getting the orders, because most of your orders are expired. Your UAS, the US is most, probably expired. So we're not talking about literally discharging registrants. Nobody was ever discharged. Your program was on hold. So when we talk about what's needed for you to reopen, I think what you said as far as orders for treatment, a UAS, a care plan, that is what we're talking about.
And it's important to keep in mind that you do not want to discharge them, certainly not retroactively, because if they've been on program is why you have been able to provide telehealth services.
Right. Nobody was ever discharged. They were just, your program was temporarily closed. Sorry if we didn't make that clear.
All right, looks like those are all the questions we received.
All right, thanks, Jeff. Gail, thank you so much. We had an extraordinary number of people participate in this webinar today, so I'm really grateful for that. This webinar is recorded, and the handout will be emailed to you either later today or perhaps tomorrow. It's going to come from Michelle Mahoney from Leading Age New York, and there's an evaluation accompanying that handout. So please fill that out and let us know how we did. You can always send your questions to me at ahill@leadingageny.org. Stay tuned for additional information coming out from Adult Day Healthcare Council. We are also planning some regional meetings in the next couple of weeks. So I hope you participate in that, and please let us know what we can do to help, and we'll keep you informed. So thanks again, everybody, and take care.